For generations, we've watched Hollywood westerns where the hero gets shot, bites down on a leather strap, and walks away minutes later. But what if that sanitized image hides a far more brutal reality? What did it truly mean to need medical care when there were no hospitals, no antibiotics, and no guarantee the person treating you had any real training? How did people survive amputations performed on kitchen tables? What tools did frontier doctors actually use? And how could a simple infection, easily treated today, become a death sentence that unfolded over agonizing days? When you truly step inside a frontier doctor's office, you discover that medical care in the Old West was so radically different, so shockingly primitive, that even our darkest assumptions don't capture the full reality. Stay until the end, because what you're about to discover will make you grateful for every advancement of modern medicine and give you a profound respect for the resilience of those who survived against impossible odds. The first shock when entering a frontier doctor's office wasn't the smell of blood or the sight of instruments. It was the realization that this was often just a room, not a clinic, not a hospital, just a converted space in a general store, a saloon back room, or the doctor's own living quarters. The examination table was frequently a wooden door laid across sawhorses, or simply the doctor's dining table, still bearing the marks of last night's meal. The floor was rough planks, stained dark in places where no amount of scrubbing could remove what had soaked into the wood grain. There were no sterile surfaces because the concept of sterility didn't exist yet. Germ theory was still being debated in the 1870s and 1880s. Most frontier doctors didn't believe invisible organisms caused disease. They thought illness came from bad air, imbalanced humors, or moral weakness. So the same table that held a patient's gangrenous leg in the morning might hold another patient's open wound that afternoon, wiped down only with a damp cloth between procedures. The doctor's hands told their own story, stained permanently dark under the fingernails, calloused from gripping instruments and holding down thrashing patients. Many doctors wore the same blood-crusted coat day after day, considering the stains a badge of experience rather than a source of contamination. In this environment, survival wasn't just about the injury or illness. It was about whether your body could fight off the infection that almost inevitably followed. And that fight began the moment you crossed the threshold, before the doctor even touched you. If the room itself was shocking, the doctor's toolkit was even more revealing. Laid out on a side table or stored in a worn leather bag, these instruments looked more like carpentry tools than medical equipment. And in many cases, that's exactly what they were. The bone saw was the most feared instrument, and for good reason. It was essentially a hacksaw with a wooden handle, the blade often reused until it became dull and had to be sharpened on a whetstone. There was no motor, no precision engineering, just a serrated edge and the doctor's arm strength. Amputations were measured in minutes because speed was the only anesthetic available. The faster the limb came off, the less time the patient spent in conscious agony. Scalpels were simple fixed blades, sharpened regularly but never truly sterile. Forceps and clamps were heavy iron implements that had to grip hard enough to hold tissue and blood vessels, leaving deep bruises on flesh even when used correctly. Needles for suturing were thick, more like upholstery needles than modern surgical instruments. The thread was often regular cotton or silk thread, sometimes even horsehair, boiled in water if the doctor was particularly cautious. Probes were long metal rods used to search inside wounds for bullets or shrapnel. The doctor would insert the probe into the wound, feeling blindly for the hard resistance of metal against bone. There was no imaging, no way to see inside the body. Everything was done by touch, by experience, by educated guessing. And every insertion of that probe brought more bacteria deeper into the tissue. The most common tool was also the simplest, the doctor's fingers, exploring wounds, setting bones, delivering babies. Direct contact was unavoidable. Gloves weren't standard. Washing hands between patients was inconsistent. The tools themselves became vectors of disease, carrying infection from one patient to the next, creating epidemics that no one understood because they couldn't see the microscopic cause. But the true horror of frontier medicine wasn't the tools or the room. It was the absence of pain control. When we say there was no anesthesia, we need to understand what that actually meant in practice. It meant full consciousness during procedures that would be unthinkable today without complete sedation. Ether and chloroform did exist by the 1860s and 1870s, but they were rare on the frontier. Supply chains were unreliable. Bottles broke during transport. Doctors hoarded what little they had for the most extreme cases, and even when available, the dosing was guesswork. Too little, and the patient felt everything. Too much, and they stopped breathing. So most frontier doctors relied on older methods. Whiskey was the most common. The patient was given as much as they could drink in a short time, enough to dull the senses but rarely enough to render them unconscious. Laudanum, a tincture of opium, was sometimes available. It reduced pain but also suppressed breathing and could easily lead to overdose. For many procedures, there was nothing at all. The patient was simply held down. This is where the leather strap comes in, the one detail Hollywood got right. Patients bit down on leather, wood, or cloth to keep from biting through their own tongues. But they also needed to be physically restrained. It typically took 4 strong men to hold down an adult during an amputation, one on each limb, pressing with full body weight. The patient's screams were expected. Thrashing was inevitable. Passing out from pain was common and actually welcomed because it meant the patient stopped fighting. Doctors worked in these conditions regularly. They learned to block out the screams, to work quickly while hands slipped on blood-slick instruments, to make life-or-death decisions in seconds while the patient convulsed beneath them. The psychological toll on both doctor and patient was immense. Many patients developed what we would now recognize as severe PTSD. Many doctors turned to alcohol to cope with the nightly memories of the suffering they'd caused while trying to heal. The procedures themselves reveal just how different frontier medicine was from anything we know today. Take a simple bullet wound. In modern emergency rooms, this means imaging, surgical extraction under anesthesia, antibiotics, and monitoring. In the Old West, it meant probing the wound with unwashed fingers or metal instruments, often making the injury worse in the attempt to find the bullet. If the bullet was near a bone, the doctor might decide to leave it in, knowing that digging further could cause fatal bleeding. If it was in the abdomen, the patient was often simply sent home to die because abdominal surgery was almost always fatal. Amputations were brutally common. A crushed leg from a wagon accident, a gunshot wound to the arm, severe frostbite, any of these could lead to amputation. The procedure was straightforward in theory, but nightmarish in practice. The doctor would tie a tourniquet above the amputation site, cutting off blood flow. Then, using the scalpel, he'd cut through skin and muscle in a circular pattern, pulling the tissue back to expose the bone. The bone saw came next, cutting through in rough, rapid strokes. The sound alone, bone grinding against metal, was enough to make observers faint. Once the limb was removed, the doctor would tie off the major blood vessels with thread, pull the skin flaps over the stump, and suture it closed. The entire procedure might take 5 to 10 minutes. The patient was awake for all of it. Survival rate was roughly 50%, and most deaths came not from the surgery itself, but from infection in the days that followed. Childbirth was another area of extreme danger. Frontier doctors often had minimal obstetric training. Complications like breech births or placental problems frequently resulted in the death of mother, child, or both. Cesarean sections were almost never performed because opening the abdomen was considered a death sentence. Forceps were used aggressively, sometimes crushing the infant's skull in the attempt to save the mother. Infections after childbirth, called childbed fever, killed countless women. Doctors moving from patient to patient without washing their hands were the primary spreaders, though they didn't know it. The difference between a good frontier doctor and a bad one often came down to factors we wouldn't even consider medical today. Experience mattered enormously. A doctor who had performed 50 amputations had learned through trial and error which techniques led to better survival rates. Speed was a genuine skill. The faster the procedure, the less blood loss, the less shock, the better the chance of survival. Confidence affected outcomes because a hesitant doctor caused more tissue damage and prolonged suffering. But there was also the question of supplies. Some doctors had access to better instruments, fresher medications, cleaner bandages. Others made do with improvised tools and reused materials. Some doctors had formal medical training from Eastern schools. Others had apprenticed with another frontier doctor, learning through observation. A few were outright charlatans with no training at all, relying on confidence and luck. Patients had no reliable way to tell the difference. There were no licenses, no regulatory boards, no malpractice lawsuits. A doctor's reputation was built entirely on who lived and who died, but even that was an unreliable measure because so many factors were beyond anyone's control. The quality of care could also depend on who you were. Wealthy patients might be treated in their own homes with the doctor's full attention. Poor patients, immigrants, and people of color often received minimal care or were turned away entirely. Native Americans were frequently denied treatment altogether. Women's pain was routinely dismissed as hysteria. The social hierarchies of the Old West were reflected and reinforced in medical care. Yet within this brutal system, there were moments of surprising skill and innovation. Some frontier doctors became experts in treating specific injuries common to their regions. Doctors in mining towns became specialists in crush injuries and toxic exposures. Doctors in cattle towns learned to treat trampling injuries and horn wounds. Some developed techniques that were ahead of their time. There are documented cases of frontier doctors performing successful emergency tracheotomies, removing tumors, and treating complex fractures with outcomes that impressed even trained surgeons from the East. The limitations forced creativity. Without proper instruments, doctors improvised. Whiskey wasn't just for pain management, it was used to clean wounds, though they didn't understand why it sometimes helped. Maggots were occasionally used to clean dead tissue from wounds, a practice that actually worked and has been revived in modern medicine. Some doctors learned from Native American healing practices, incorporating herbal remedies that had genuine medicinal properties. But these successes were exceptions in a landscape of suffering. For every innovative treatment, there were dozens of deaths from infections that antibiotics would cure in days. For every successful surgery, there were amputations that didn't need to happen, performed because the doctor lacked the knowledge or tools to save the limb. To conclude, reflect on this. When we look inside the medical practices of the Old West, we're not just studying history. We're witnessing the razor's edge between life and death that our ancestors walked every single day. No anesthesia, no antibiotics, no understanding of infection, just raw human endurance, desperate improvisation, and the thin hope that the body's own resilience would be enough. The frontier doctor's office was a place where the limits of human suffering were tested daily, where the screams of conscious patients during surgery were so common they barely drew attention from passers-by, where a simple cut could become a death sentence, and where surviving a medical procedure often meant surviving despite the treatment, not because of it. Understanding this reality changes how we see the Old West. It wasn't just a place of adventure and opportunity. It was a place where the human body was vulnerable in ways we can barely imagine today, where pain was an expected part of healing, and where death was always close, waiting in the invisible world of bacteria that no one could see or fight. Every time you take an antibiotic, receive anesthesia, or visit a sterile hospital room, you're experiencing a miracle that frontier patients would have considered impossible. The distance between their world and ours isn't measured in years. It's measured in millions of lives saved by knowledge they didn't have and tools they couldn't imagine. This isn't just medical history. It's a reminder of how fragile human life has always been, and how recent our ability to truly fight back against suffering really is. The Old West wasn't won just by gunslingers and pioneers. It was survived by people who endured unimaginable pain and kept going anyway, knowing that tomorrow might bring the injury or illness that no doctor, no matter how skilled or dedicated, could save them from.